Namaste, future doctors, and welcome to the ward. Get your stethoscopes ready because today we have an absolutely brilliant session lined up for you. We're tackling one of the most classic, super high yield, and honestly kind of confusing topics in all of internal medicine: nephritic versus nephrotic syndrome. I know, the names sound almost exactly the same, but trust me, by the end of our time together, you're going to know exactly how to tell them apart. We're treating this explainer like a virtual ward round, complete with a cinematic 3D journey right into the microscopic filtration units of the kidney. Okay, let's dive into this. So, as your senior attending today, here's our roadmap. We'll start with a welcome to the ward to set our golden rules. Then we'll hit core pathophysiology, move on to visualizing the symptoms at the bedside, spend some time decoding the lab reports, and finally, we'll wrap the whole thing up with our final diagnostic strategy. All right, Section 1. Welcome to the ward. The golden equations. Before we even step foot near a patient, you need to anchor your mind with two absolute golden rules. The core trigger is the absolute key here. For nephritic syndrome, notice the I in nephritic. I want you to think inflammation. Picture angry, swollen, actively inflamed blood vessels inside the kidney. That intense inflammation directly causes blood to leak out, which gives us hematuria, and it causes fluid retention, which gives us hypertension. So nephritic equals inflammation. Got it? Now, contrast that with our second golden equation. For nephrotic syndrome, notice the O. Think of an open hole, a filtration defect. The kidney's microscopic sieve is basically broken. It's not angry and inflamed anymore, it's just physically leaky. This structural defect lets massive amounts of protein slip right through, leading to proteinuria, which then sets off this whole cascade causing massive edema and hyperlipidemia. Nephrotic equals filtration defect. To bring it all together, we have this brilliantly detailed master map of renal syndromes. It compares everything from the basic pathophysiology down to the specific urinalysis. Now, don't panic. You don't need to write a MAR or memorize every single row right this second. We're going to break down all these specific markers together. Just keep this mental anchor in mind as we walk the ward today. Moving right along to Section 2, core pathophysiology. Into the glomerulus. I want you to literally close your eyes for a second and imagine shrinking down to a microscopic size. We are stepping right inside the 3D structure of the kidney. Welcome to the microscopic battleground. On the nephritic side, we're seeing violent glomerular inflammation. It's actively attacking and damaging the capillary walls, tearing them open just enough to let red blood cells, or RBCs, leak out. It's physical damage driven by an overactive, angry immune system. But look over at the nephrotic side. The primary issue here is podocyte damage. Podocytes are those little foot processes that act as a strict barrier. When they get damaged, glomerular permeability to proteins completely shoots up. It's not a violent inflammatory tear, it's a quiet structural failure of the protein barrier. All right, let's zoom back out to human size. Section 3, visualizing the symptoms. We're stepping up to the patient's bedside now. What are we actually seeing with our own eyes? The crucial clinical sign here is the edema, the swelling. In a nephritic patient, the edema is usually just mild to moderate. You're typically going to see it around the eyes, that periorbital edema, especially right when the patient wakes up in the morning. But in a nephrotic patient, it's a completely different ballgame. Because they're losing so much protein in their urine, they lose the oncotic pressure that normally keeps fluid inside their blood vessels. The result? Severe, generalized edema all over the body, known clinically as anasarca. So it's a puffy eye in the morning versus massive, full-body swelling. Next, we strap on the blood pressure cuff. For the nephritic patient, hypertension is super common. Their inflamed kidneys are holding onto fluid and salt, basically driving that pressure straight up. But for the nephrotic patient, their blood pressure might be completely normal or just slightly elevated. Sure, they're incredibly swollen, but that fluid is leaking out into their tissues. It isn't necessarily building up high pressure inside the actual blood vessels. Okay, let's step away from the ward and walk down to the pathology lab. Section 4, decoding the lab reports. This is where we look at the hard numbers to confirm our bedside suspicions. Pay very, very close attention to this specific number because I promise you it is guaranteed to be on your exams. Proteinuria. The nephritic patient has mild to moderate protein in their urine. We're talking less than 3.5 grams per day. But the nephritic patient, because of that massive filtration defect we visualized earlier, they have massive proteinuria. They are losing greater than 3.5 grams of protein every single day. That 3.5 is your magic cutoff number. Do not forget it. Now, what about blood? Well, hematuria is super prominent in nephritic syndrome. And we're not just talking about normal red blood cells, they're dysmorphic. Think about it. Because they had to physically squeeze through those violently inflamed, damaged capillary walls, they get all deformed and mashed up. You'll also see RBC casts. On the flip side, in nephrotic syndrome, hematuria is usually absent, or at most just microscopic. And look at how this builds a complete systemic picture. Because nephrotic patients are constantly leaking protein, they develop marked hypoalbuminemia, really low albumin in the blood. So what happens? Their liver absolutely panics. It tries to compensate for the lost protein by wildly churning out lipids, which leads to marked hyperlipidemia. Nephritic patients, they usually don't have this issue. However, nephritic patients often show low complement levels, specifically C3 and C4, especially in conditions like post-strep glomerulonephritis or lupus nephritis. Why? Because their immune system is actively burning through these proteins during the inflammation. Nephrotic complement levels, on the other hand, usually stay totally normal. Let's look directly through the microscope now. The pathologist report for a nephritic patient is crystal clear. You're going to see red blood cells, those crucial RBC casts, which prove beyond a shadow of a doubt that the bleeding is happening way up in the glomerulus, and just mild proteinuria. But shift your focus to the nephrotic patient sample, and it's a completely different vibe under the lens. The urinalysis shows heavy proteinuria. And remember that hyperlipidemia we just talked about? That causes lipiduria, literal fat in the urine. You'll see fatty casts, and under polarized light, you will see the ultimate classic exam buzzword, Maltese crosses. Seriously, if you see the phrase Maltese crosses, you blindly tick nephrotic syndrome and move on. Which brings us to our final section for today's rotation. Section 5, Final Diagnostic Strategy, the bottom line. So how do we actually synthesize all this data into a definitive, confident diagnosis when we're standing right there with the patient's chart? It all boils down to these core diagnostic features. Your absolute key diagnostic feature for nephritic syndrome is hematuria with RBC casts. That is your undeniable proof of glomerular inflammation. For nephrotic syndrome, your key is the classic triad: massive proteinuria, which causes hypoalbuminemia, which ultimately results in severe edema. And that brings us full circle, right back to where we started with our golden equations. Nephritic equals inflammation, nephrotic equals filtration defect. Once you understand this fundamental difference in the mechanism, every single downstream symptom and lab result makes perfect logical sense. So next time you see a patient with puffy eyes and high BP, or a patient with full body swelling and heavy protein, you'll know exactly what's going down at the microscopic level. But what happens when a patient presents with a mix of both syndromes at the exact same time? That's a puzzle for you to chew on. Keep studying, keep asking those tough clinical questions, and I'll catch you on the next ward round.